Good afternoon and welcome. I am Enrique Garrido, academic coordinator and moderator of this presentation, the second edition of the International Master in Sleep Medicine. It is my pleasure to be here with all of you this afternoon. Now I would like to introduce to all of you the speakers who will be with us today. Dr. Diego García-Borreguero, neurologist and psychiatrist, director of the master program. Good afternoon.
Hi, good afternoon.
Dr. Celia García, neurologist, coordinator of the master program.
Hello.
Good afternoon. Dr. Sofía Romero, pneumologist, coordinator of the master program.
Good afternoon.
And Dr. Cristina Álvarez, who will be joining us online, is the Vice Dean of Postgraduate Studies in the School of Biomedical and Health Science of the Universidad Europea. Before we begin the master presentation, it would be interesting to discuss the reality of sleep medicine with the students who are currently watching us. Dr. García-Borreguero, what can you tell us about the field of sleep medicine?
Well, sleep medicine is an area of medicine that has emerged over the last, let's say, 40, 50 years. The previous assumption in medicine was that the physiology of the human body during sleep was alike the one during wakefulness. And accordingly, the disorders, the conditions that would arise during wakefulness, and that by then were quite well studied, would basically be the same as the ones that could appear during sleep. So the sleeping body is should be, according to that, quite similar to the human physiology while the patient is awake. That proved to be completely wrong. And as a result of investigating the human body and the functioning of the different physiological systems while the humans were asleep, a number of conditions were found. For example, the typical example was sleep apnea, obstructive sleep apnea syndrome. The physiology, the functioning of respiration, of breathing, changes dramatically during sleep. And you will find conditions that will only emerge while the patient is asleep, and you won't see them when the patient is awake. And that was the beginning of an area that has developed until now. Approximately 89 different conditions have been found. It's an area that is shared by specialists of very different backgrounds, like, for example, pulmonologists, of course, neurologists, psychiatrists, endocrinologists, pediatricians, dentists. I mean, it's really a multidisciplinary area where it's recognized, it's acknowledged as a subspecialty in many developed countries, and like the United States or Germany and also in several other European countries. It's an area that is really developing and of major interest for anyone that might be interested in knowing further about her own patients.
Okay, thank you very much.
Thanks.
Let's now discuss the International Master in Sleep Medicine, Dr. García Malo. What were the reasons for developing this master program, and what learning objectives will be covered by the students who enroll?
Well, the first thing I would like to mention is, as described by Dr. García-Borreguero, this is like the paradigm of multidisciplinary medical area, because our patients are not pure neurological or pure pulmonological. So from my point of view as a neurologist, I had to learn a little bit more about pulmonology or psychiatry and so on to treat properly our patients. And that was the first reason why we started thinking about developing this kind of master's degree, because we wanted to make it truly multidisciplinary. The second part was to try to make it as much practical as possible, to help our students to learn how to think in a clinical practice. Then, as some of our countries do not count with a specialty on sleep medicine, when some of us who wants to work for sleep medicine, we have to go and pass a specific exam, such as, for example, the European Sleep Research Society exam and certification. And we also wanted this master to serve as a preparation for passing this kind of exams. So we want our students to have as very reliable material and updated material to prepare these exams. And the last point was to count with high-level experts in every sleep field and learn from them, can interact with them. And I think that were the main reasons why we started thinking about creating this exciting master we are now on.
Thank you very much. And talking about the methodology, Dr. Romero, what is the methodology used for this master program, and what advantages does it over traditional classroom teaching?
The main objective of this master is the study of sleep medicine from a multidisciplinary kind of view. For this objective, we have created a 100% online training platform. In this online training platform, the students will allow to combine their study during the master with the work activity. This also allows the students have access whenever they want to the master material and also at any time. The total duration of the master will be around 1 year, and for the training will be carried out through online classes recorded by teachers. That can be followed in English or Spanish, depend of the preference of the students, and anytime. Another advantage of this master is the realization of live monthly webinars with the world's experts in sleep medicine. The students will have the opportunity to interact live with these experts during this webinar, and also ask the question that they will have during this webinar.
Okay, thank you very much. Another very important aspect that a student is interested in knowing when he or she enrolls in an online master is that in many occasions he or she has the feeling of being alone, no? So in this case, Dr. Romero, how has this reality been managed and solved in this master?
One of the benefits of this master is that all the students will have support and accompaniment at all times. For that, we have tutorials, workshops, and personal meeting that will allow the students to feel that they are with us in all time. The online tutorial will allow the students to meet another colleagues who are studying the same master and also share the same doubts and concerns. Also, the students will have a forum discussion and email in the learning online platform. If we detect some student needs, we try to solve it very, very fast.
Okay, thank you very much. And with respect the faculty members, Dr. García-Borreguero, what kind of specialist teaches the classes?
Sure, let me say first, we follow the specific textbook, which is the European textbook of sleep medicine. It's called the ESRS textbook of sleep medicine. It's a compendium. It's one of the main compendiums, one of the main textbooks in the world. But this one is also the material that we use for those students that, after the master's degree, want to take the European examination in sleep medicine, the so-called ESRS certification in somnology. We follow exactly the same track, so that after doing the master's degree, they should be ready to take the ESRS examination, which is also one of the most prestigious ones in the world. And we have two levels of teachers. The ones that teach the normal chapters in the book. These are all specialists, local sleep specialists. But in addition to that, we have a number of world experts that for each chapter will give a webinar. And this is one of the points that needs to be emphasized mostly. These are really world-class experts. For example, just to name a few of them, we have with us Dr. Luis de Licea. He's a neurobiologist from Stanford University. He was the person that described the hypocretins, which is one of the main discoveries in neuroscience over the last 30 years. And I don't think that I'm exaggerating by saying that. It's really recognized as one of them. We will have in sleep, in pediatric sleep, Dr. Dennis Rosen from Harvard University. In neurology, we'll have Dr. Federica Provini from, she's from Bologna University in Italy. She's probably one of the main, or if not, or maybe even the world's main expert in sleep-related movement disorders. Dr. Lammers for narcolepsy, Dr. Colin Espy from the UK, from Oxford University, for cognitive behavioral therapy. In sleep-disordered breathing, we have from Sydney, from the University of Sydney in Australia, Dr. Ron Grunstein, one of the popes in the world in sleep apnea. We'll have also people from Asia like Manvir Bhatia, a neurologist from New Delhi. So, I mean, this is just a brief sample of experts who will have students will have the opportunity to interact with them. This will be direct. I mean, you might see also the webinar as a recording later on if you cannot make it on the time, but if you watch it live, you will be able to interact with them, ask them anything you wanted about the topic. So it's a unique opportunity, and it's really a top-level kind of faculty.
Mm-hmm. Thank you very much. Mm-hmm. Talking about the modules and chapters, Dr. García Malo, what modules and chapters will be covered in the master's program, and what additional documentation will the student receive?
Well, we will cover all sleep medicine. We will begin with first module, which is about normal sleep and physiology of sleep. Then we will also talk about the clinical evaluation of our patients. And then in chapter 3, we will present the complementary tests that are nowadays available for evaluation of these patients. The second module will be all about sleep pathology. We will discuss and we will present all sleep disorders. We will go from, from parasomnia, epilepsy, sleep-related movement disorders, sleep apnea, of course, and we will treat all of them. We will present pathophysiology, diagnosis, updated treatments for these conditions. And then I want to mention the internship, the most practical part of the master, which is around 48 hours. And this will consist on the presentation of clinical cases by experts on sleep medicine who will discuss how they try to think about the patient and try to solve the clinical problem. Then we also encourage our students to present clinical cases themselves so that we can connect and be online with them and discuss these clinical cases so we can all learn from these situations. Sometimes additional workshops will be presented according to the students' need. We will follow, as Dr. García-Borreguero mentioned, the European Sleep Research Society textbook. And then we will include in our virtual platform an article repository where we can put some updated papers that can be of interest for students.
Thank you very much. There is a training tool of special relevance in this master, which is not easy to find in other masters. I'm referring to the live webinars with renowned international experts. Dr. García-Borreguero, Could you explain in more detail what this tool consists of and the advantages of being able to count on it?
Sure. I mean, the first, as I mentioned before, it's a lecture provided by someone that has been working all his or her life on the same topic. So these are really people that they dream on that they think every minute of their life on the topic they're teaching. And the amount of experience, of clinical experience that these experts have is absolutely important. That's something that not that many other masters can offer. The other thing is that we allow the expert not to follow during the webinar necessarily the textbook. During the normal lectures, we just follow, as I mentioned before, the textbook, and we try to summarize it and make it easier to understand for the student, to tell the student what is more relevant, etc. Thinking also that there will be, having in mind that there will be at some point an exam, and also that there are certain things that the student has to memorize. However, during the webinars, the expert is free to improvise whatever they think it's relevant in that field, and so they will get an update of what is really the cutting-edge knowledge in the field.
Mm-hmm. Thank you very much. Mm-hmm. Another of the differentiating components of the master is the possibility for a student to take additional internships. So in this way, Dr. Romero, could you explain a little more about this possibility?
Indeed, we offer online or face-to-face internship in our centers. This possibility is very interesting because the students will allow to obtain hours of practical training during this online or face-to-face. That is very important to obtain the Sleep European accreditation. Mm-hmm. This is a very good possibility.
Okay. May I say something to that?
Yes,
add something to what Dr. Romero just mentioned.
Yes.
So the way it works, I mean, there are two options. One of them is to come over to Spain or to any of our centers. We have 2 centers in South America as well. That's ideal, but that's sometimes not possible. You have to spend, it's a question of money, it's a question of giving up your job, getting permission from your hospital, etc., etc., etc. No? For many of the students, this is not going to work that easily. However, what we offer is the possibility to be sitting with us together while we see patients. Mm-hmm. So basically what we do is we have a computer with a camera, we turn the camera so that virtually the student is sitting next to me, mm-hmm. seeing the patient. So what we do, we interview the patient and then we start chatting with mm-hmm. the student. Mm-hmm. Making some reflections or considerations on what the diagnostic problem might be, what the therapeutic approach could be. It's like learning medicine in real life. Mm-hmm. In addition to the question of the certificate, which is also very important because many of these degrees require a certification. Mm-hmm. I mean, require a letter stating that the student mm-hmm. has gone through that and that number of hours mm-hmm. doing sleep medicine. You will learn sleep medicine in the same way probably as any of you learned your specialty when you started working in a hospital with a senior colleague. That's what you will get without moving from your hometown.
Okay, thank you very much. Very interesting. So far we have talked about the methodology, faculty, the content, documentation, follow-up with the students, and the webinars. Now it's time to know what the students have to do in order to receive the International Master in Sleep Medicine degree. There are 2 types of tests. One of them is the continuous evaluation, and the master final thesis is the In this sense, Dr. García Malo, what will be the evaluations consist of and how many will be there?
Well, we will have 4 evaluations throughout the year. For every evaluations, we have 2 calls during like 2 weeks. And the exams will be multiple choice exams.
Mm-hmm. Thank you very much. And about the final thesis, can you explain in more detail how it will be carried out?
Yeah, the students will be asked to prepare a final thesis after the master's program. They can do it in groups if they prefer. They can prepare an original investigation or a review on any topic related with sleep medicine. They will have a tutor who monitors if everything is going okay through the preparation of this final thesis. And then the thesis will be presented and examined by a board. And for those of them or those works of higher interest, of higher quality, we will promote publication on scientific journals.
Okay, thank you very much. In addition to everything you have seen so far, we wanted to highlight and reinforce 2 more aspects. One is to complete the students' learning through clinical cases, which take on special relevance in this master degree. Last but not least is the participation of the Universidad Europea. In regard to the clinical cases and the importance of the multidisciplinary approach, Dr. García-Borreguero will share with us an example by presenting a case through which we exercise learning. On a case of memory loss and insomnia, the importance of sleep.
Okay, well, thank you very much. As we mentioned before, part of the practical training will consist of case presentations. These case presentations will be done by us, similar to the one I'm going to do in a minute, but also you will provide them. So you will, as the training, as the master's program goes on, you will be asked to present a case of your own, if you have any, and discuss it in public, and you will learn with us aspects of treatment, diagnosis, etc. Okay, on today's case, what I want there are 2 messages that I would like to get across. One of them is the one that we mentioned already. Sleep medicine is an multidisciplinary area. At times you feel a pulmonologist, at times you feel an internist, at times you feel a neurologist, sometimes you feel a psychiatrist, and many, many times you feel a psychologist. You feel like a psychologist. You become practicing sleep medicine on a given afternoon. You go across all these specialties throughout the night. Sometimes you feel like a dentist, like a sleep dentist. It's really, you will be able to talk to people from very, very different backgrounds that have something in common with you, which is the interest in sleep medicine. The other thing I would like to get across with this case is the following. Even while you practice your specialty, you might make use of sleep medicine, and that will enrich your practice of medicine immensely, significantly. In the case I'm going to present, you will do that, exactly that, with, it's for a case of a patient with cognitive dysfunction. So it would be something, let's say, for a psychiatrist, or, well, depends on what country, normally for a neurologist, psychiatry, and how you might enrich your handling of the patient by understanding sleep medicine. Okay, so I called it on a case of memory loss and poor sleep, why we need to look into sleep. Okay, it's a case that we saw in our clinic recently, not that long ago. It's a male, 59 years old, that came to the clinic, and the complaint was poor sleep and insufficient memory loss. The patient had always snored, and before coming to us, the patient had been diagnosed like 5 years before from sleep apnea. He had undergone a sleep study years before, and I never saw the report. But in that sleep study, he told me the number of apneas was approximately 50 per hour. So they decided that 50 per hour is normally severe sleep apnea. Anything that goes beyond 30, adding together apneas and hypopneas per hour of sleep, anything beyond 30 is considered severe. So 50 is very severe. And accordingly, he had been prescribed Cpap at a pressure of 8 centimeters of water pressure. However, there was a very poor compliance. The patient wouldn't use it for even 3 hours a night at the beginning, at best. Later on, the patient decided not to use it at all anymore. As a result of that, the patient was sleepy during the day with an Epworth Sleepiness Score, which is a rating scale that measures the degree, the subjective degree of sleepiness. And he scored 15 out of 24 points. 24 would be the absolute maximum in terms of sleepiness. 15 is already pathological, but it's like I would call it moderately pathological. The patient had also been pre-diagnosed for restless legs syndrome. He would move a lot at night, but a previous neurologist had diagnosed the patient for restless leg syndrome. Bed routines were the following, more or less. He would go to bed at 12:30, well after midnight, to 1 a.m. Why to bother going before that? Because probably he wouldn't fall asleep. So it was nothing he chose, but it was something there was no other option. He would fall asleep quite quickly at the time already, in less than 10 minutes. But approximately half an hour later, he would start waking up, and the entire structure of the night was falling asleep, getting up. It was a very fragmented sleep with lots of sleep interruptions until he got up at 7 in the morning, and he would have an average subjective total sleep time of less than 3 hours. That's what he told us. Okay. Sorry, I'm having some technical. Okay. The past medical history. The patient was obese with a BMI of 32.7. You can see just below the patient was 98 kilograms. That's like almost 200 pounds. 98 kilograms heavy, and he was 173 centimeters tall. As a result of the obesity, the patient had undergone a gastric bypass in 2005. So before that, he was even more obese than that. He suffered from arterial hypertension, diabetes mellitus type 2, dyslipidemia, was suffering from ischemic heart disease with a myocardial infarct, and had been placed, according to his statement, 5 different stents. 5 stents had been inserted. He also suffered from intestinal diverticulosis. He had been a smoker. He had been a heavy smoker until 5 years before, probably until the first myocardial infarction. The medical and neurological evaluation, particularly the neurological evaluation, didn't show very much. But if you look here, there are 5 different risk factors, cardiovascular risk factors. The first one is the obesity. The second one is the hypertension. The third one is the diabetes. The fourth one, the dyslipidemia, and also the previous presence of ischemic heart disease. All these, and also the smoking. So he had all the different tickets to have a severe cardiovascular disease. That's what we knew at that point. Okay, then We ran several questionnaires, the Insomnia Severity Index, where he ranked quite high. He scored quite high with a 24 out of 28, so that's severe insomnia. Although, despite the fact that he was, as we will see in the next slide, under hypnotic medication. On the Hamilton rating scale for depression, he's ranked at 11 out of 52, which means mild depression, very mild depression. It's not completely normal, but it's not a severe depression. As I mentioned before, the Epworth Sleepiness Scale, 15 out of 24, which means mild, moderate daytime sleepiness, which is a little bit surprising given the few hours he slept and the severity of the sleep apnea, but that was his subjective opinion. And we also run the International Restless Leg Study Group scale, where he showed a 31 out of 40, that means severe RLS. Okay, treatments. He was currently being treated with pramipexole, a dopamine agonist, at a relatively high dose, 1.5 milligrams per day. For a patient with restless legs, that's quite a lot. In addition, he was also being treated with clonazepam, benzodiazepine. That's the hypnotic I was referring before too. He was also being treated with amlodipine for the heart condition, also for the hypertension, hydrochlorothiazide, bedagliptin for the diabetes, liraglutide for the injections, also for the diabetes and the obesity, pitavastatin for the dyslipidemia, ezetimibe for the dyslipidemia as well, and also acetyl salicylic acid. For the RLS, before the pramipexole, he had been treated with high doses of both ropinirole and rotigotine, the other two dopamine agonists. Well, what we knew about the RLS, he was having a discomfort in the legs, in the lower part of the legs, but, and they started distally and bilaterally, but later on, and the drugs, initially the ropinirole helped him a lot, but later on, not so much anymore. And with the course of time, these initially distal symptoms became more proximal. They never reached the level of affecting the arms or the trunk, but they reached the entire leg as a result of the ongoing treatment. He had been treated with ropinirole 0.5 to 1 milligrams initially, that he responded, but later on, that was not sufficient any longer, so the dose had to be increased to 4 milligrams per day, which is the highest dose you can give, you can administer of ropinirole in an RLS patient. Symptoms had been getting worse over the years, more and more, so the dose had to be increased, and now we were at the limit because we were already treating him with the last of the dopamine agonists, pramipexole, with the highest doses possible. Lately, symptoms had been starting earlier in the afternoon when the patient relaxed. So initially, symptoms had been starting at the beginning of dinner time, 8, 9 p.m., but as a result of the worsening of the condition, now symptoms were starting already after lunch. We performed, we were not able to obtain the PSG, so we performed the PSG, and we'll show you all of that. But please, let me just, for the sake of time, go to the basic things. He slept not even 4 hours, 222 minutes. He slept 62% of the time that we gave him sleep. He fell asleep very quickly in 1.5 minutes and stayed awake for almost 2 hours during the rest of the night. The sleep architecture was, I can say it in one sentence, a lot of superficial sleep, little deep sleep or REM sleep. So that's a typical marker of a very fragmented sleep. In addition to that, we found a number of periodic leg movements, which are leg jerks that are very typical of RLS. During the master's degree, you will hear a lot about them. So we count the PLM index both during sleep and while awake. The one during sleep was 23 leg jerks per hour of sleep. That's a lot. That's increased. But during wakefulness, in the periods of time that patients stayed awake during the night, he showed even more, 52 per hour. Regarding the respiratory, so we got almost 3.5 to 4 hours of sleep. And in that period of time, we found 56, adding together apneas and hypopneas and respiratory-related arousals of the EEG. You'll hear a lot about these concepts whenever we talk about sleep apnea. He came to 56 events per hour. These events occurred as frequently during while the patient was sleeping on the lateral decubitus as when the patient was sleeping in the supine position. So it was not a positional kind of apnea. Regarding the oxygen, the one awake was fine, 94%. The mean was a little bit low, 89%, and the lowest SaO2 during REM sleep was, during REM sleep it came back down to 66%, and during in the minimal value was 77 per night. The patient spent 71% of the night with suboptimal SaO2 values. So in one word, in one sentence, as I explain it to the patient, he was hypoxemic for a lot of time, but not very hypoxemic during that time. And the EKG was fine, was okay. We were wondering, since the Epworth Sleepiness Scale score is just 15, whether, well, we performed a maintenance of wakefulness test. That's a test in which we ask the patient a number of times in the morning to stay for 40 minutes. We did it here, in this case, 3 times, 40 minutes. And we were in a dark room without any acoustic noise or any environmental factors that might arouse the patient. Eyes closed, EEG on, and we told the patient, try to stay awake. The normal thing, any of you, if I asked you to do that, at least the minimum you would stay awake would be, I would say, 19, 20 minutes. This patient on the first of the test stayed awake for 6 minutes, then 8. So he was clearly somnolent. This was a pathological sleepiness. The mean was 7 minutes, 28 seconds. That's just to contrast with what the patient perceives. One thing is perception, the other thing is objectivity. And so we came to the conclusion, no positional sleep apnea, fragmented sleep with PLMs. In addition to that, we performed a multiple suggested immobilization test. Here the patient, that's something we do before the PSG. The patient is awake, as you can see, is half sitting in bed with the legs stretched out and separated. And what we tell the patient is try not to move, and what we saw here is, okay, it's visually very interesting. So the patient is showing leg jerks throughout the night. Imagine with that to try to fall asleep. It would be just impossible. I mean, imagine you have that throughout the entire night. The other thing is that we also ask the patient on a visual analog scale every 10 minutes on 2 of the tests. We did this twice to score between 0 and 10, being 10 the worst. and being 0, no symptoms, the severity of his symptoms. And you can see here it's a 0, sorry, it's a 1, 2, 3, 5, 5. So as time goes on, symptoms get worse and worse and worse. And on the second test, more of the same, 0, 3, 4, 5, 5, 5, 7. So you can see here that these leg jerks and these aesthesias, this disturbance is depending on the time of the day, because it gets worse in the second test compared to the first one. And immobility, trying to remain immobile, worsens them. Okay, we came to the conclusion that there had been a worsening under the dopaminergic medication. So the criteria for dopaminergic augmentation are, just to say it briefly, it's an earlier onset of symptoms in the afternoon. He had that. Shorter latency to symptoms at rest. Yes, always compared to before the treatment had been initiated. An overall increase in symptom intensity, that was the case. Longer latency until onset of therapeutic effects, that was also the case. An expansion to the arms, trunk, or abdomen. This was not the case here. But still, he met criteria for dopaminergic augmentation. So what does it mean in one sentence? The dopamine agonist initially alleviates symptoms, but later on, if you keep the treatment over a longer period of time, you will see that it does less and less and less with the course of time. And at some point, it will turn around and do exactly the opposite. From being a tool that improved symptoms, that alleviated symptoms, it turns to the contrary. It becomes a tool that exacerbates symptoms. And this is the nature of dopaminergic augmentation. He was suffering from that. It's very common in RLS patients that are being treated with high doses of dopaminergics. So it's a iatrogenic worsening with the drugs that you are giving the patient to help him. We looked also into the iron levels, and what we found there was that, I'll just summarize it for you, ferritin and transferrin saturation are okay. Everything is okay in serum iron. Everything is okay. However, ferritin and transferrin saturation are close to the lower margin of normality. Okay, we know by experience and by research that the main problem in these patients is not a peripheral iron deficiency. The main problem, what causes the RLS, is a brain iron deficiency. How can we see how iron is in the brain? Well, the easiest way, it's a technique that was developed a few years ago by Dr. García Malo, sitting next to me, is by means of quantified transcranial sonography. It's something that you can do easily as many times as you need, because it's harmless for the patient. And what you do is you measure the echodensity of the substantia nigra. The substantia nigra it's a structure in the brain that is the main iron store for iron. And what we do there is we measure the ecodensity, because it's assumed that the more iron there is, the higher the ecodensity. We come to the so-called substantia nigra ecodensity index, which is okay, which is it reflects the surface of the substantia nigra. The higher the ecodensity, the higher the number will be. It's an indirect reflection of the content of brain iron in the substantia nigra, not in the brain, but in the substantia nigra. And the substantia nigra is the main iron store in the brain, so it's really the one that matters most. It was a 0.15. Is that high? Is that low? Well, normally you need at least 0.21, 0.22. It's low. It's definitely low here. So we can really say that we can really say that the patient was having a brain iron deficiency. I'm having some problems with the marker passing the slides. And I might need some help because it takes a while to... Okay. So in other words, what we find here is that the patient has marginally low serum iron values, and it has definitely low brain iron values. And that might explain the emergence of the RLS. The patient also complained of cognitive problems. He would misplace things increasingly and used more frequently notes and reminders. He was 59, I remind you. The relatives reported questions needed to be repeated. Increasingly, patient did not keep track of appointments or dates. The patient needed to be reminded of names of close relatives and friends. Moderate difficulties to follow when reading. Okay, the typical question here is, to what degree is this age-related? You are getting older, yeah. That's a typical thing that everybody thinks at the very beginning. The question is, how sure are you that this doesn't go a little bit beyond your age? So we interviewed the patient with the mini-mental state examination. Neurologists and psychiatrists are very familiar with this tool. It can be done in 10 minutes. And it measures very quickly in quite a standard way orientation, registration. By the registration, I mean the capacity to memorize things, at least to memorize initially on the short-term things. Attentional calculation, recall, I mean the capacity to retrieve whatever you have memorized before a couple of minutes later, language, and pentagons. So it measures several cognitive functions. What we found here is that he scored the maximum in orientation to time and place, also in registration. He didn't score the maximum in attention and calculation, so here we get a little deficit in attention. He didn't score well at all in recall. He was not able to retrieve the information learned before, and he didn't score the highest on language. So he got a 26 out of 30, which is a little bit under what is expected for a normal person. So these are the three areas of deficits. The diagnostic criteria for mild cognitive impairment are, first of all, a concern either by the patient, by a relative, or by a skilled clinician that there is a change in condition, a change to the worse. The objective evidence of impairment in cognitive testing, that could be one, the mini-mental scale could be one. In cognitive domains like memory, executive function, attention, language, visual-spatial skills. But while having that, the patient preserves independence in areas of daily living. It's a patient that can do everything by himself, doesn't need anything, just has a little bit of a cognitive deficit, just that. And the patient has no significant impairment in social or occupational functioning. It's not demented. So far, what are the diagnoses? First, by polysomnography, obstructive sleep apnea. That's definite. Severe obstructive sleep apnea. By polysomnography, but particularly by the a multiple suggested immobilization test, restless leg syndrome undergoing dopaminergic augmentation. Third, brain iron deficiency by transcranial sonography. And also by means of the neuropsychological testing. I'm not getting into, we did the MMSE, we also performed later on the Montreal Cognitive Assessment. It showed the same thing, and we put the patient for finer neuropsychological testing. That last thing wouldn't be strictly necessary, but I'm just going to the basic diagnostic tools. So the MMSE showed a mild cognitive impairment, and that could be sleep-related. It could be also vascular disease related. Does the patient have a vascular disease? We don't know. Let's see. Or Alzheimer's disease related. There are other reasons for that. It could be also pharmacological. There are many reasons. Okay, I'm going to show you what we did in order to investigate that. But first, the therapeutic strategy was A, improve RLS, because RLS is at this point creating the main obstacle to treat sleep apnea. Unless you treat the RLS, the patient was not able to use the Cpap machine because of the RLS. The RLS was he wouldn't feel comfortable at all with the RLS and the Cpap on top of it. So either you improve, either you unlock the RLS by treatment, or you won't be able to treat the sleep apnea, and you will have also the daytime sleepiness. Step number 2 would be, once this is achieved, treat the obstructive sleep apnea, and then reevaluate sleep again, and the EDS, the excessive daytime sleepiness. On top of that, in parallel, if you want, improve the cardiovascular function as much as you can, and reevaluate the cognitive function thereafter. Okay, what to do with the RLS? The first thing, what are the options for the RLS? First, change drugs. Well, problems. Patient is already on high doses of pramipexole, I said it before, and alternative dopamine agonists have already been tried. What other drugs do we have here? The alpha-2 delta ligands, like gabapentin or pregabalin, or even the latest one, dipyridamole, that works on adenosine. I don't think that in this kind of patient, these drugs are likely going to be effective, so we didn't even try them. Tramadol, okay, could be one of the options, or oxycodone, a mild opiate that it's approved for treatment-resistant RLS in Europe. The patient was here, so I know that there are, I mean, in other countries to obtain oxycodone might be difficult, but okay, I'm going to show you the way we treated, we solved the question here. We went for oxycodone at a dose of 5 milligrams per day. There is one problem. The patient is mildly hypoxemic. We normally look for, we measure arterial gases in order to see how high particularly the CO2 is. Because if the CO2 is high, you might reach, by administering a mild opiate, a further respiratory depression and complicate the whole thing. The approach would have had to be different. But in this case, it was not the case, so we got green light to go on with the oxycodone. That's something that Dr. Romero certified, and so I felt free to do it. Okay, iron status. Yeah, as I mentioned, serum iron is marginally low. It's still okay, to be honest, but brain iron is low. So we have to make sure that the iron gets into the brain. So what do? We decided to administer ferric carboxymaltose, 1,000 milligrams administration, and see the effects. I'm not going to talk long about iron treatment. You will get a lecture, a specific lecture on how to do that in RLS patients, but just look at what we obtained at the first of all, the echogenicity index from being 0.15 jumped over 6 months later. It's a slow treatment, I know. It goes slowly up. There's no way to speed it up, but it went from 0.15 to 0.21, which is, whoa, it's already looking nice already at 0.21. It was a patient that absorbed the iron quite well. Ferritin jumped from 35 to 410. It's a little bit high, but no problem, no problem. That's exactly what we want. We want the patient to be mildly hyperferropenic for a few weeks or months. We do that together with a hematologist. It's a calculated risk. At the same time, the TSAT went from 21 to 29, fine, and what we ultimately wanted. The IRLS scale, which initially was at 31, severe RLS, fell down to 16 out of 40, which is already mild RLS. Together with the drugs, and later on, a few months later, with the iron, we were able to improve the condition significantly. Already with the drugs, after administration of oxycodone, we were able, the patient was sufficiently mild in terms of the RLS to be able to undergo a Cpap titration. And that's what you see. This is the report of the Cpap study. Again, like the previous study, we came to the conclusion that 8 centimeters were fine. And once the Cpap was administered and the patient was able to sleep longer, the ESS, this Epworth Sleepiness Scale, fell from 15 to 6. The patient, 6 is, anything under 10 is normal. 6 is a perfectly normal score. He was no longer somnolent during the day. What about the cognitive situation? Now that the patient is no longer sleepy. Well, there you can see this is the result, and there is only one thing that is not right here. I mean, attention has improved significantly. Language has improved, but recall has not improved, pointing to a persistent, despite the Cpap and the improvement of nighttime sleep, this suggests that there is an ongoing memory problem and a so-called amnestic cognitive impairment. Which kind of cognitive dysfunction is caused by sleep deprivation? Sleep deprivation normally leads to impairments in alertness and in concentration. That's a typical thing for sleep deprivation, but also in executive functioning. With that, the patient becomes more difficult to focus and pay attention on things, becomes easily confused, etc. Also, sleep-deprived patients have difficulties in performing tasks that require logical reasoning and complex thoughts. The question here is, what kind of cognitive impairment does the patient have? It's not entirely sleep-related. It was partially sleep-related, but not all of it is sleep-related. So if you use neurologists know this quite well, and also internists know it well, the so-called modified Hachinsky ischemic score, you get a number of features and the score that you might give them. So we filled this out, and what we saw here, well, we gave fluctuating scores, that was okay. A little bit of depression, yeah, he gets another score there. There was we were not available. We were not aware at the time that the patient had undergone. He was hypertense, but we were not aware of previous strokes. So I put that as a 0 with a question mark. So the total number is 5. Normally, anything under 4 suggests strongly Alzheimer's disease. Anything over 7 suggests strongly vascular dementia. Our patient has 5, so it's somewhere in between, in the gray zone. We performed an MRI, and we got 2 specific findings. One of them is the so-called degeneration of the white matter, leukoariosis, particularly periventricular, and also silent strokes. The patient had undergone strokes without silent, in the sense that these were not associated to any symptoms. And this kind of finding is highly suggestive of a hypertensive arteriopathy. It's also very common in patients undergoing diabetes. Our patient has diabetes, type 2, and smoking. Our patient was a smoker. So there is an element of vascular dependent cognitive impairment. Is that all? Well, I don't know, because when we looked at the hippocampus, we were able to see a mild atrophy of the hippocampus. The hippocampus is a structure, it's a brain structure that is very, very important in the connection of memories. An atrophy of the hippocampus means normally some problem in memory, and that points very directly to a potential Alzheimer's disease. How to know this? How to know this in this case? Well, first of all, let's look at just neurologically, the patient, the neurological examination was normal. There was no gait disturbance, no Parkinsonism, no behavioral abnormalities, no stepwise decline, just amnestic deficits. Out of the epidemiological studies show that most of the dementias, this is not a dementia yet, but it's a dementia in the making, in the process, are vascular. It's a mixture of vascular and Alzheimer's disease related. The second group is pure Alzheimer's disease, and the third group is pure vascular. The fourth group would be a mixture of Alzheimer's, vascular, and Lewy body disease. So the point I want to make here is that the mixture of vascular and Alzheimer's is quite a common thing. Okay, what happens? What's the relationship between sleep and Alzheimer's disease? Just to say it very briefly, neurons have proteins that cross the membrane and are called precursor. The name of the protein is the precursor protein beta amyloid. These are proteins that cross the membrane. The function is not very clear, but they seem to have a role in the intercommunication between neurons. Normally there is a process of cutting these long proteins in pieces by a kind of protein called secretase, and one of the pieces emerging from that is the so-called beta amyloids. We all produce beta amyloid. That's part of physiology. However, the difference is that in Alzheimer's disease, these beta amyloids accumulates, sticks together, creates aggregates, insoluble aggregates, and at the end, these aggregates kill the neuron. It's as if you were not able to get your garbage at your home cleaned up every day, and at the end the garbage is able to kill you. It might at some point. So it's something similar, oversimplifying it a little bit. Okay, what does it have to do with sleep? Yeah, if you look at the CSF in the cerebrospinal fluid, the CSF levels of beta amyloid, there is a kind of a circadian curve. And if the levels are maximal at the end of the day, yes, the longer you have been awake, the more garbage you have. Let's call it for now garbage, beta amyloid. During the night, during sleep, not during the night, during the sleep, there is a garbage collection system called the lymphatic system. It's a perivascular brain cleaning system that has the function, it's turned on during sleep, and it will recollect it. So that means during the night, the levels of beta amyloid, which is potentially toxic, decrease. decrease. And in fact, you can see on the right side that the longer, I mean, if you put someone under sleep deprivation, the longer the sleep deprivation, the less hours someone sleeps, the more beta amyloid accumulates in several areas, particularly in the hippocampus. So sleep is one of the mechanisms you have to defend yourself against the accumulation of the beta amyloid. Well, there are ways to measure it. How do you want to diagnose Alzheimer's? I know the diagnosis is a clinical one so far, but the degree of uncertainty, the problem right now is that by the end, the patient has all the symptoms, all the features of Alzheimer's disease, all the damage in the brain has been done already. There's little more to do. And that's one of the reasons why drugs are not effective. So it becomes crucial to be able to detect the accumulation of beta amyloid as soon as possible. And there are several techniques. These are expensive techniques. These are based on PET scan. These are you have in many hospitals this kind of, in some hospitals these PET scans, but it's still expensive. It's not available for the common public. You can measure both beta amyloid and also very soon you will be able to measure tau, which is another protein that accumulates in the brain. A recent finding has shown that you can measure beta amyloid. There are two ways, by PET scan. The other one would be by measuring it in the cerebral spinal fluid by means of a lumbar puncture. Are you going to do a lumbar puncture on everyone that has memory problems on this patient? I would say no. However, you can draw blood. And by drawing blood, and if you measure beta amyloid in plasma, you will see that the levels are, and these levels are predictive for whatever is happening in the brain. Low levels of ratio of two different kind of beta amyloids, the 42 versus the 40, suggest that the same finding might be found in the brain, in the CSF. We did this and we got a finding of 0.06. A finding of 0.06 is somewhere between the one you can see on the left-hand slide, it's the one between MCI and Alzheimer's disease. And for the tau protein, we found exactly the same thing. So the patient was highly suspicious of suffering from Alzheimer's disease as well. And this is my last slide. Knowing this, we decided. What about treatment? We can always try. This is a patient with mild cognitive impairment, with very mild one. Cholinesterase inhibitors have not been effective. You can always try them, but no trial has shown them to be very effective. The alternative is targeting, I'm really having trouble with the pointer, monoclonal antibodies. This is an emerging therapy. These are antibodies that will selectively locate the beta amyloid and interact with it and neutralize it and make it and be able to eliminate it. So the first of these drugs has been recently a year ago approved in the United States, is currently being examined in Europe, and there is another one that is currently under examination by the FDA. So it looks as if the future was going to look very similar to that. But there are other things that you can do on top of that. Treatment of vascular factors, we mentioned that. Since this is a vascular dependent memory impairment, try to treat it as aggressively as needed. The Cpap is absolutely a must. I really feel ashamed for the lost time, for the many years of lost time that the patient had not received his Cpap. We might have been able to improve sleep by that and by that, not only to improve the quality of life of this patient, but also to improve, to slow down, possibly to slow down the progression of Alzheimer's disease. And this was my last slide, and I hope that you get the main message that sleep matters. It matters in many diseases. The number of diseases that are affected by sleep is important. And you, by learning sleep medicine, you might get a very different perspective, even of your own specialty. Of course, you might show interest in intrinsic sleep disorders, and also use them, get into that field and become one of our colleagues. So I welcome you to join our field, to join the master's degree first, and then to join our field. We will have this kind of seminars throughout the master's degree. So you will learn with us on specific cases. Thank you very much, and I will be happy to answer any questions if any of these arise.
So thank you very much for Dr. García-Borreguero for presenting us this interesting clinical case. So move on to the discussion with the director and the coordinators. So do you have any questions for the director?
I wanted to make a short reflection on your clinical case, that I enjoyed your clinical case. I wanted to highlight how important and how complex medicine can be, and I think that your clinical case was absolutely brilliant for exemplifying this fact, because in this clinical case you have required the help from pulmonologists, hematologists, and so on, of course, neurologist, that you are a neurologist. And I found it very, very interesting for helping us to know how important is the multidisciplinary approach. I don't know if you have a specific question. I was wondering, because you talk about the circadian rhythm of beta-amyloid in the cerebrospinal fluid, and I was wondering if there is a circadian rhythm in the plasmatic beta-amyloid. I don't know if you have to
I don't know of any
answer.
paper that has examined that question. In fact, it's a very good question, because I'm not aware of any. I haven't looked specifically at that. It's a very good question. It's a lot easier to do than to measure it on the CSF, of course.
Yeah.
And in fact, you're pointing out at one of the problems. The way of measuring it has not been standardized yet, to my knowledge. So do we have to sample blood in the morning, or do we have to do it in the evening? In this case, I think we do it like at 11 in the morning, something like that. But there are no guidelines to my knowledge. This is a finding that was described for the first time, I think it was a year ago, or in 2020. It has been replicated since. I see a number of papers and position papers and discussion groups that are starting to look into the new perspective of treating Alzheimer's disease with these plasma-based biomarkers. But one of the things that will be needed before that is to standardize the collection and also the way of measuring it, etc. I know that these assays are commercially available, so it's not
very,
difficult
very
to
interesting for neurologists.
Yeah.
And I was also wondering, because you reached the conclusion that it was both Alzheimer and both vascular, and I don't know if you want to say a few words on vascular risk, because the patients suffer sleep apnea, hypertension, and how PLMs. And I don't know if you want to say a few words on vascular risk derived from all these sleep disorders.
Sure. Okay. First of all, the patient had a number of infarcts that were silent. So, to my knowledge, no one had performed an MRI before. The previous doctors were aware about the cardiovascular risk. Yeah, he had an infarction before, but not about the cerebral, not of the brain infarctions. I think that once this is detected, most standard care takes into account quit smoking, lose weight. He'd lost already some weight, but well, he needed to lose a lot more. But, you know, for example, it's so rare to look into sleep apnea. It's so rare. The American Academy of Cardiology has established that following an infarction, a sleep study, following a brain infarction, a sleep study is mandatory in order to be able to, I don't know, however, I was reading data the other day showing that only 7% of all the cases of stroke in the United States, undergo a PSG or any sleep measurement for sleep apnea. So, I mean, I can imagine that in most cases this risk factor undergoes without noticing. It's very important to take care of all the different vascular risk factors, and this is certainly one of them. The PLMs, we need to do a lot of education regarding the PLMs. PLMs are also another marker of increasing, they are a risk factor of increasing hypertension during the night, and they might be a precursor of stroke, at least a risk factor for stroke. Yeah. Mm-hmm.
Mm-hmm. I have one question for you, like pneumologist I am. Yeah. What do you think about the paper of Cpap in the treatment of neurocognitive dysfunction? Do you think that we need to try to improve the Cpap adherence and tolerance in this kind of patients?
Absolutely, absolutely. This is a case of a patient that just wouldn't tolerate it, and nobody tried hard enough. You know, at the end what we need is different specialties to collaborate together. I can imagine that this patient had gone to one specialist, and that specialist said, well, he doesn't tolerate it, he feels anxious at night. He wouldn't have consulted, or he wouldn't have spoken with his the neurologist colleague. The neurologist probably didn't speak to the pulmonologist neither, and so at the end, I mean, the ultimate goal is to increase Cpap compliance. This patient, well, initially he was using it less than 3 hours, that's too low, but later on he went from that to not using it at all, to keeping it at home. And having this, you know, this is a patient that is at a very high risk for suffering a stroke, another stroke, and this time probably not a silent one anymore.
Mm-hmm. If the last question, maybe. Do you know what are the physiopathologic mechanisms that are involved in the obstructive sleep apnea and the neurocognitive dysfunction?
Two of them, two very important ones, are first of all the degree, well, hypoxemia. But when hypoxemia is not transitory, it's on and off. How you would call it?
Intermittent or intermittent?
Intermittent, sorry, it didn't fall the word to me. Intermittent hypoxemia, that has a higher effect on the regulation on the vascular regulation in the brain. That's by itself a risk factor. In addition, the fact of just by being hypoxemia per se, that will, I mean, the little blood that is getting into the brain comes with low content of oxygen. The other factor that might be playing a role is the sleep fragmentation. Sleep fragmentation by itself represents or reflects it will reflect in overactivation of the sympathetic nervous system during the night. That might be related to increased hypertension, arterial hypertension, and that by itself might be a cause for a stroke, either hemorrhagic or ischemic. Mm-hmm.
Mm-hmm. Yeah. No more question? Okay. Thank you very much for this interesting discussion. So we have already seen another of the important pillars in the learning methodology of this master, the clinical case. Another aspect that is particularly relevant in this endorsement and prestige of is the Universidad Europea, the Vice Dean of Postgraduate Studies of the School of Biomedical and Health Science at Universidad Europea, Cristina Álvarez, will introduce us to the Universidad Europea. We have a video of her.
Good afternoon, everyone. I'm Cristina Álvarez, Vice Dean of Postgraduate Studies at the Faculty of Biomedical and Health Science in the Universidad Europea. First of all, I want to apologize for not being able to be with you in person, but I could not refuse the opportunity to participate in this event. I would like to welcome you to Universidad Europea, a Spanish private university with campuses in Madrid, Valencia, the Canary Islands, and Lisbon. The team that will lead this master is located in Madrid, where we have 2 university campuses, one in Villaviciosa de Odón and the other in Alcobendas, as well as 2 university clinics, one undergraduate and one postgraduate. We have more than 16,000 students. 1 in 3 are international students, and specifically in the Faculty of Biomedical and Health Science, we have more than 5,000 students in several areas like medicine, nursing, nutrition, psychology, pharmacy, biotechnology, dentistry, and now also in biomedicine and vet. Today, I am really happy of being here to present the 2nd edition of the International Master in Sleep Medicine, in which we have the great opportunity to go with the best partner, the International Sleep Institute. The International Master Degree in Sleep Medicine is a title from Universidad Europea, with 60 credits ECTAs. And for translating this outside of the academic language, I would like to share some context about the European higher education area. This area emerged in 1999 through the Bologna process to give greater coherence to higher education system across Europe. Thus, this area was established to facilitate student and staff mobility, also to make higher education more inclusive and accessible, and to make higher education in Europe more attractive and competitive on a global scale. All the participating countries agreed to introduce a 3-cycle higher education system consisting of bachelor, master's, and doctoral studies. They also ensure mutual recognition of qualification and learning periods completed at other universities. And of course, they implement a quality assurance system in order to reinforce the quality and relevance of learning and teaching. In addition, the European Credit Transfer and Accumulation System, ECTS, appears as a tool of the European higher education area to make grades and course more transparent. ECTS credits represent training based on well-defined learning outcomes and students' workload. Thus, an ECTS credit is equivalent to 25 hours of students' work inside and outside the classroom. That means that both the hours in which the students are in the classroom and those outside the classroom are computed. All this calculation makes a master's degree with 60 ECTAs equivalent of a full year of study. I hope this context to be useful to you and will help you to assess the workload of the master. Welcome again, and thanks to the International Sleep Institute for this wonderful collaboration. Enjoy the masterclass.
Well, so thank you very much, Cristina, for your presentation. By way of a closing remark, as you can see from what we have presented of the master program, Dr. García-Borreguero, in conclusion, why take this master?
Well, I mentioned 2 of the main reasons already. The one is that if you want to get into that field, also if you want to enlarge the perspective you have on your own field, sleep is related to endocrinology, it's related to even to gynecology, it's related to every aspect of internal medicine, it's related to neurology, to psychiatry. You could make change your practice very much. Also, if you are thinking of opening a sleep laboratory, the way to do that is by doing this master's degree. You will learn about the different techniques needed to run a sleep laboratory. It will be a new experience for you, and you might also improve your proficiency in your own in your medical knowledge.
Mm-hmm. Thank you very much. Mm-hmm. Finally, before saying goodbye to the second edition of the master program, we would like to share with you the testimony of some of the students who are taking this master program, so you can hear firsthand their comments and feelings.
Mis impresiones, después de un año de haber estado en este Máster Internacional de Medicina del Sueño de la Universidad Europea, han sido realmente satisfactorias.
My impressions after almost 1 year in this master's degree really couldn't be better.
Es un máster excelente que ofrece herramientas para el tratamiento de los pacientes.
Nos ponen al día de las últimas novedades. Es un profesorado súper profesional.
Acompañándome sin más en cada uno de mis pasos, de mi crecimiento académico.
It's an excellent program. I've been really enjoying the lectures. We're lectured by the experts in the field from all over the world.
Este curso ha sido muy interesante para mí, para mi desarrollo profesional.
La impresión que me da esto es que va a ampliar los horizontes en cuanto al manejo, al diagnóstico y al manejo de la patología en sueño.
Pues los puntos fuertes de este máster son principalmente el que podemos convivir con grandes especialistas en la materia.
All the teachers are highly qualified in the subjects they teach.
Los webinars que se realizan cada vez que se van viendo los temas, en donde se invitan a los mejores especialistas reconocidos a nivel internacional.
Voces muy importantes que nos han enseñado cómo manejar esta patología.
Y además una plataforma muy amigable donde queda guardada todas las clases, y si no las puedes ver en vivo, la puedes ver en diferido.
The master is bilingual, is a huge advantage because we can have access to all the lectures in English, in Spanish, or in both if we want.
We are lectured by the experts in the field, and it's such a nice opportunity to have contact with these people.
Mis pacientes también se han visto beneficiados con los conocimientos adquiridos a través del máster.
Un diagnóstico oportuno, un tratamiento certero y a generar confianza en mis pacientes.
Lo recomendaría a todas las personas interesadas en profundizar más.
Por supuesto lo recomendaría y lo he recomendado, ya que es un máster que te permite crecer, dar un paso superior en tu formación profesional.
Estoy muy agradecida y muy contenta de haber realizado este máster con la Universidad Europea y el Instituto de Sueño.
Realmente se nota una calidad académica que volvería a elegir 1 y 1000 veces.
We thank to Dr. García-Borreguero, Dr. García Malo, Dr. Romero, Dr. Cristina Álvarez for their presentation to the second edition of the Master. Thank you very much to everyone, and especially to the people who have been following us throughout digital channels and YouTube. And with this, we conclude the presentations. Thank you very much.
Thank you.